Now we're going to talk about upper cervical instability. We're going to get into this a little bit. I made other videos on this where we get into this because this is all of it is very detailed, but we're going to talk about the upper cervical instability. There's no discs here. So you can see this wonderful illustration that I took from a radiologist. It's beautiful. And what we're looking at is, are these ligaments and these membranes still intact and holding the regions? So what are some common signs of upper cervical instability? How many of you watching get pain in the back of your head? That could be enough. Like, I have pain. That could be irritation of the upper cervical instability. A lot of times we see dizziness, headaches, not feeling great, pressure in your head, other things like that can also be signs. We're narrowing this due to time. So this is a pretty extreme example of a patient of ours from years ago that was involved in a crash, got evaluated at the hospital, an image. Didn't see this. We did a DMX on him, and this is what happened. And again, this is no fracture. This is soft tissue.
Diagnosed with whiplash, had flexion extension x-rays, and it was missed.
Here's something else that you'll see if you watch C1 at the top here, that top bone. This person in mid-phase, you'll see how the vertebra pops. It floats. Watch. Bloop. Missed because you can't move unless we DMX you. Look, bloop. And that's even some occipital condyle irritation or instability. C1 open mouth, we're looking at the accessory and alar ligaments. Show you this here. It's a very hard view to get. I analyze it, stop it when I see the problem, measure it. We're looking at these abnormalities. So here's a great illustration that just shows where we kind of look at the line just for, if you have upper cervical instability, it can look like this. I'll show you here. And we just drew that line in to show you what we're looking at there, okay? So we also have fixed and minimized this pathology with the treatment. Here's a pre and post. This woman had C1 cut in half. That's why you can't see it on here. She also had a fake disc replacement with a significant cervical kyphosis and upper cervical instability. We treated her, we improved her cervical curve, we minimized her upper cervical instability. We've seen a lot of these patients, and that paper is also being published soon. C1 injuries and motor vehicle crashes, you had a trauma. The upper cervical spine ligaments, specifically the alar ligaments, have been associated with whiplash injury in clinical work using range of motion studies like the DMX. In frontal and rear impacts, the highest predicted distractions in the upper cervical spine were for the apical and alar ligaments. We know these ligaments are susceptible to trauma. That was published in Journal of Biomechanics. The AAI, the axial instability, results most commonly from trauma due to injury of the transverse odontoid ligament. The atlanto-occipital joint, the most mobile in the body, is stabilized primarily by ligaments. Therefore, AAI is not uncommon in conditions of lax ligaments, trauma, EDS, other things, but we don't know if you have upper cervical instability unless we really DMX you. And failure to diagnose AAI resides in the difficulty of recognizing rotatory instability on standard X-ray, CT, and MRI. That's why we want to do the DMX to really identify, and they actually did use a DMX in neurosurgical review back in 2020 to identify these pathologies because they're missed. We also published a paper that we got into the Spine Journal talking about upper cervical ligaments. This was back in 2009. We've been talking about these injuries, banging our heads against the wall because no one would listen to us, and finally, patients are being listened to and taken a little more serious of what we've been trying to say here. We'll talk a little bit about anteposition. I'm not going to read this to you, but in car crashes, if your head is turned, that also can increase the likelihood of injury. Now, is upper cervical instability, UCIS, a problem? Well, let's take a look at what we found in our paper. What you can see here, C1, C2 lateral overhang. We found that in 63% of the injured patients and only 32% of the non-injured. The C1, C2 periodontoid space, another measurement we take, we found that in 28% of the injured and only 3.9% of the non-injured. Now what's interesting with this is we never saw both on an asymptomatic individual. So if there was both, there's according to this data, it's about 100% likelihood of injury. What we found, this is again from our paper, Model 3 results. I mentioned this where you have an 88% likelihood with 2 or more, or 92. So what does it all mean? Well, this is what we have published in our paper. Okay, these results provide convincing evidence for several conclusions. One, intervertebral stability is a common finding in the symptomatic population of patients with chronic neck pain after whiplash trauma. And two, intervertebral instability is an uncommon finding in the uninjured population. Three, the finding of 2 or more abnormal parameters of intervertebral motion during the DMX examination of the cervical spine is a highly accurate diagnostic test for identifying patients with chronic neck pain after whiplash trauma. So if you're out there suffering and you come to us and we do a DMX and we see you have instability, that is a common finding in injured people. It is uncommon in asymptomatic individual. And the technique and the procedure that we are using, the DMX, is highly accurate. So if somebody says to you, like, I don't care what that test shows, I don't read it, that's not what the science or the data is supporting. You need to find another provider potentially. These findings have importance, again, this is right from our paper, given a number of prior publications demonstrating equivocal or negative MRI results in patients with acute and chronic whiplash, a body of literature that has been transformed into a myth that whiplash is a soft tissue injury that cannot be detected with medical imaging. The repetition of this myth has, in turn, resulted in a number of non-organic explanations of chronic pain complaints after whiplash trauma, including symptom exaggeration, malingering, and secondary gain. How many of you out there that have instability are being told by docs, you're faking, it's not really there? We know these are real problems. We know they are. We've published it, we've proved it, we've helped patients with this, hundreds, thousands of patients with this. But given the high prevalence of ligament injury in the chronic whiplash population and the lack of such findings in the uninjured population, the attribution of complaints to a non-organic source in any chronic whiplash patient without first ruling out pathology via DMX imaging in the cervical spine is unfounded. Come to our office, let us image you, let us get you this report, link it to our paper. You need this information so you can get the appropriate care and treatment. Conclusions we have in our paper is the DMX exam of the cervical spine is a highly accurate test for identifying patients with symptomatic ligamentous instability after whiplash trauma. The imaging modality should be utilized more widely in the clinical investigation of chronic post-whiplash pain. So, let us help you. The conclusion is, if you get a DMX with our office, you are going with the most experienced docs with the DMX. We've had it for a long time and we're the authors of the largest biomechanical paper of this. An IME, if it's an insurance company, cannot rebut our paper if I do it here. They can if you do it at another center. If we do the DMX, they can't rebut our own paper and our findings. So we can help you with that, especially if it's a car crash. We can explain what's happening, what our paper says. And the insurance company most likely will not be able to hire a doc to go against our paper because they're trying to argue with the author of a paper. And with a DMX at our office, it's going to give an incredibly detailed report. And if you come to us for treatment or an evaluation, an amazing evaluation that we can help you. We've been doing this for 20 years. We've been trying to help patients that maybe just like you have been told you're lying, you're faking, these aren't real injuries. We know that's false and we publish that information to help you. Let us help you. Come to our office, give us a call. We've done Zoom consults with patients, but certainly getting the DMX at our office is a huge benefit. And if you do not DMX, if a person who's hurt in a crash or damaged or having problems, if you don't have a DMX, you do not know if they have several of these pathologies. And then we don't know what your short and long-term health care is going to be. If you can't rule it out, or if you can't rule it in, you have to rule it out. So thank you for listening. I know this was long. I might try to break this up into certain pieces, but again, let us help you. Getting a DMX at Katz Chiropractic and Rehabilitation Clinic with my wife and I, authors of this paper, very experienced docs can give you the most detailed report you can get. There's other centers out there that are great. You can give me a call. I know many of them, but there's also centers out there that are just doing really quick, not even giving reports, really don't understand this. Let us help you save a bunch of time and money. Come to our office, give us a call. Let us help you get to someone that could do it accurately if you can't get here. And we know a lot of those centers. So thank you so much. Again, my name is Dr. Evan Katz with my wife, Dr. Shauna Katz in Boulder, Colorado. We look forward to doing everything we can to help. We know both clinically and personally how damaging pain can be and how it can rob your life. And we want to do everything we can to try to fix why you're in pain so you can get a better quality of life. So thanks so much. I hope you found this informative, and I really look forward to hearing from you.